everyone, and thank you for all being here, both online and offline. My name is Nomin-Erdene, and I'm here presenting today with my team members, Carlee, Linder, Nguyen, and Alison Stoopler. And our master's research project focuses on fall risk reduction, specifically reduction in older adults, specifically developing an evidence-based knowledge tool translation that incorporates adult learning strategies. We'll begin by presenting the background and the
Okay. Oh, not even.
I click on the computer.
Maybe the mouse?
She has to manage it.
She has to stay attention.
Try the arrows in the computer.
Maybe if you click on it. Or click on like the presentation. Now we're on the Zoom.
So we'll maybe stop the sharing and we'll,
Oh, there.
okay.
Oh, is it the mouse? Did you click the mouse?
Yeah, you can use the mouse.
So we'll begin by presenting the background and the objectives of our project, followed by an overview of the methodology. Then we will share our results and conclude with a discussion of the results implication on our deliverable. Okay, so the World Health Organization defines a fall as an event that results in a person coming to rest unintentionally on the ground or the lower level. In Canada, falls are the leading cause of injury-related hospitalizations and deaths among adults aged 65 and older. And the falls result in significant physical consequences, such as fractures and head injuries, as well as psychological impacts, such as fear of falling, loss of confidence, along with depression and social isolation. The impact extends beyond the individual. Falls place a very heavy economic burden on the healthcare system due to hospital stays, rehabilitation, and increased need for long-term care. And the costs are rising as our population ages. So what is fall prevention? Fall prevention refers to strategies and interventions aimed at both reducing the likelihood of a fall and the severity of injuries if a fall occurs. According to clinical practice guidelines, effective fall prevention involves assessing individual risk factors such as history of falls, gait, balance issues, and medications, as well as cognitive status. Promoting physical activity, particularly strength and balance exercises. Psychological interventions such as CBT, mindfulness to target behavior changes, addressing environmental hazards such as improving lighting and installing grab bars or removing tripping hazards, as well as manage sensory and health issue by providing regular vision and hearing care, addressing urinary urgency, or optimizing chronic condition management. And lastly, providing education so that older adults are aware of their risks and have the knowledge to take preventive action. So the common fall prevention strategies given or advice to older adults closely mirror the guidelines, as we can see. However, the challenge is not just providing these general advice, but it's making sure that they're communicated effectively so that the older adults can apply them in their daily lives. That's where fall prevention education comes in. Fall prevention education is a structured approach to increase knowledge, awareness, and healthy behaviors that reduce fall risk. It's traditionally offered in hospital, long-term care homes, community centers, and it's typically community centers. It's often delivered at key transition points, like just before the discharge or post-fall, post-surgery, or as part of general geriatric care. During fall prevention education sessions, various tools and methods are used, including face-to-face discussions, video, or structured presentations, supported by printed materials to reinforce key messages. The content delivered in these sessions reflect the strategies and topics that we outlined earlier. Teaching approach that is primarily didactic, relying on passive learning methods like presentations or lectures. Beyond these structured sessions, a wide range of educational materials are offered to the public. These include fall prevention brochures, pamphlets, and booklets, which may be distributed in healthcare or community settings or accessed through online. Some are comprehensive, covering most or all fall prevention topics that we mentioned earlier, and others are more focused, targeting a single area such as exercise programs, home safety checklists, or self-risk assessment tools. These resources target different audiences. For example, health professionals to support program planning and implementation, or older adults offering plain language tips and practical tools, or both older adults and their caregivers as co-use resources promoting joint learning.
So while we're taking into consideration the content that is being presented to older adults, the method of delivery is another factor we must consider. Over the course of the summer, our team has observed different methods of delivering information to our target population. As we designed a draft workbook for our research project, we believe it was necessary to understand what is currently being provided. And after reviewing 3 different pamphlets online, it was observed that the pamphlets included the following. Some had myths and facts sections, a checklist of environmental hazards, and a space for a reflexive question. On the other hand, it should be noted that they rarely utilized visuals and appeared very wordy with small written fonts. Continuing on with the current learning strategies for older adults, we had the opportunity of observing Catherine Booth's fall prevention workshop. Later on, Emily will discuss this further, but I'll provide a brief overview. While the patients received individual OT sessions throughout their week, Catherine Booth also offers fall prevention workshops to patients who have recently fallen or who they believe are deemed at risk of potential falls in the future. Along with the patients, caregivers and family members are also encouraged to attend the workshop. One OT leads the session using a PowerPoint presentation, which was most recently revised in 2022. Their presentation includes a variety of learning strategies, which include visuals, videos, interactive questions to boost engagement, and a few personal anecdotes dependent on the OT presenting. And at the end of the session, patients also receive a pamphlet. With all the background information we just discussed, it came to our attention that there are some gaps in the knowledge. First, the tool Catherine Booth is currently using may not be up to date with the most evidence-based practice as it was last revised in 2022. The original strategies may not have implemented level 1A evidence, and for that reason, we believe it should be beneficial to review the relevance of the current content. Second, while it's important to review the content that our target population is receiving, reviewing how it is being delivered is also necessary. Right now, they are using a PowerPoint presentation as their education delivery method. While they use a variety of learning strategies mentioned in the previous slide, there is a gap in the effectiveness of this method. Further consideration on whether there is a more advantageous and interactive tool that Catherine Booth Hospital can implement for their fall prevention workshops may be beneficial. Okay. So with that being said, our objectives are as follows. Our general objective is to co-design and provide evidence-based fall prevention recommendations through literature review and consultation with frontline occupational therapists working in an inpatient geriatric population. More specifically, we have 2 specific objectives. Our first one, to conduct a literature review on evidence-based fall prevention strategies and learning strategies for a geriatric inpatient population, and provide an outline of an interactive fall prevention workbook that can be used with this population. And our second one is to consult Catherine Booth's occupational therapist and other clinicians to adapt the evidence-based recommendations to the local context to ensure applicability of our KT tool.
So now we will be talking about the methodology of our research project. So our project started with a virtual meeting with our clinical and faculty supervisors to discuss the objectives of the project in the fall of 2024. So as per discussions, the original objective was to ensure that their current knowledge translation tool, which is their PowerPoint presentation, was evidence-based in its content and learning strategies used. So after the virtual meeting, our clinical supervisors sent us the slides of the PowerPoint presentation and a feedback survey on their fall prevention sessions, which was previously done by a student/project. We could look it over and start reviewing it. So PowerPoint presentation consisted of 33 slides and it was last revised in April 2022. The background was white and blue with writing in black and red and included some pictures and YouTube videos. So during our review of the PowerPoint, we noted down some points that could be improved, such as the very condensed slides, the unclear outline of the presentation, and the small writing. As for the feedback survey, it was obtained from 21 participants in a duration of 5 classes with a total of 2 presenters, and it consisted of a satisfaction questionnaire of 12 yes or no or multiple choice questions. The general consensus of the feedback was that the sessions were greatly appreciated by the participants. However, the participants noted that some aspects of the presentations needed improvement, such as the lack of active group participation and the content not being individualized enough. So for the observation, so to have a better idea of the execution of the fall prevention sessions, we decided to attend and observe one session to view the session from the participants' point of view. So this allowed us to understand the context in which the KT tool is being delivered, to identify the gaps in the practice of the tool, and gauge the participants' engagement with the content. Overall, the session lasted approximately 1.5 hours with no breaks, and there were 6 patients and 1 family member in attendance, with an OT from Catherine Booth giving the presentation. During the observation session, some important points on the location, setup, content, and learning strategies used were noted. So some examples would be the small screen, which made it difficult to see the writing on the slide, especially since we were seated in the back, and the limited space in which the presentation is delivered, which limits the number of people who can attend the session overall. And we also found that there was too much information given in one continuous session, and there was minimal participant engagement. So with these two factors coupled together, it led the presentation to feel didactic and passive, as noted by the participants' nonverbal communication. So right after the fall prevention session, we gathered with our clinical supervisors, the other OTs at Catherine Booth, and the PhD student of our clinical supervisor. The purpose of this meeting was to discuss on our observations of the session and identify the knowledge and practice gaps of the current KT tool observed by us and those noted by the OTs giving the session. As the overall objective of the project was to adapt the current tool to the local context. So during the meeting, multiple practice gaps were brought up, such as the lack of personnel and room availability, the patient's different physical and cognitive language levels. As these barriers were being brought up in our discussions, we brainstormed some possible solutions to these barriers to adopt the tool to the local context. So one example was to streamline the information through a shared document, so the information shared during the sessions are the same regardless of the presenter. Another was to have the class broken down in 2 different sessions, so the presenters would have time to elaborate more on the different fall risk factors instead of providing only a brief overview. This would also allow the participants to share their own experiences. Another one was to create invitation cards that would be distributed to the participants a few days before the session to explain the purpose of the session and to have them start thinking of their own fall risks.
Okay, so moving on to the research phase of our project, we began gathering the evidence related to different sections with each team member focusing, conducting our own focus review. To gather the evidence related to fear of fall, its impact, and recommended interventions. We conducted a structured literature search primarily using the Ovid Medline database. Search terms included combinations of keywords such as older adult, fear of falling, accidental fall, interventions, etc., and all linked using the Boolean term and. To ensure the inclusion of high quality evidence, results were then limited to systematic reviews. We supplemented the search with Google Scholar to capture additional relevant studies that may not have appeared in the initial database search.
So for the literature review of the non-modifiable risk factors, a preliminary search was done to find which ones were the most relevant to our population. So this was done using Ovid Medline database by searching key terms such as falls, intrinsic risk factors, and older adults. A filter was also applied to the search to include only meta-analyses, RCTs, and systematic reviews in order to find level 1A articles. So following discussions with my other team members and our faculty supervisor, the most important non-modifiable risk factors identified were incontinence, peripheral neuropathy, vision loss, chronic conditions, and a history of falls. So once the most pertinent risk indicators were found, a more in-depth search was done for each risk indicator using Ovid Medline again, and filtering for only meta-analyses and systematic reviews. Someone else do it.
Too much. Too much? Okay, oh, here we go.
So another search method that was using AI databases. After a discussion with our faculty supervisor, we discussed the use of AI in literature review and search. So one of the key points that we had discussed was the idea of when you're using an AI database to search something, you shouldn't be asking questions that you don't already have an idea of the answer to. So after discussions with the faculty supervisor and amongst our team for the internal and external risk factors, we decided to bring our search to Perplexity AI. So once we got an idea of what we were expecting to find, we entered the search, what are the most effective exercise interventions for reducing fall risk in older adults proven in level 1A evidence. And AI was then able to generate level 1A sources that we weren't necessarily able to find through Ovid Medline or through using key search terms in other databases. So once we got the articles there, we were able to go into the articles themselves and gain more information on these internal modifiable risk factors that we are looking for and use the information from those articles to further narrow down our search terms for AI to find more specific and more useful articles. So that's kind of how we got a lot of our information for the internal risk factor section was through AI searches.
And then for the external factors, our faculty supervisor also assisted us in retrieving level 1A articles regarding the external factors. So in a meeting that took place in November, she conducted a search with us using the keywords home modifications and fall reduction and randomized clinical trial. And from there, we were able to retrieve 3 different level 1A evidence articles.
Okay, so similar search methods to fear of falling were used in this section for cognition, risky behavior, and management search strategy. With the addition of reference materials on SARO provided directly by our faculty supervisor after an extensive database search did not find relevant and or recent high quality material. Consistent research methods were employed here as well for the effective education methods or learning strategies using Ovid Medline database and supplemented with PubMed and also AI like Perplexity AI and Elicit AI to ensure a thorough review of relevant evidence after the Ovid Medline or the PubMed database search was exhausted. The prompt displayed on the slide is used to guide the searches, and all articles were then screened for relevance and alignment with our project objectives, specifically its context.
So following the literature review,
Just to mention before, important to know that during our individual lit review, we called every week to discuss the findings and see if anyone had needed additional help, if they encountered any difficulties during the search.
okay, so following the literature review, we had a second meeting with Catherine Booth with her clinical and faculty supervisors and the other OTs to share our findings and discuss the future direction of the project moving forward. So it was during this meeting that the overall objective of the project was changed from adapting the PowerPoint presentation to the local context to creating a new KT tool in the form of an interactive workbook. So during our discussions with the stakeholders, it was brought up that Catherine Booth's current KT tool presented itself as a barrier to knowledge use. So the tool was not adapted to the local context as the fall prevention sessions were too long to consolidate all the condensed information being provided, as we had pointed out in the first meeting. It was also discussed that the formatting of the tool was not in line with the evidence-based learning strategies found in the literature review. So because of this, it was decided that the creation of a new KT tool would be better to address the barriers in the local context and allow for the process to be reproducible and the knowledge to be generalizable.
So after that second meeting that Emily discussed with the Catherine Booth stakeholders, we had solidified the idea that we would do a fall prevention workbook instead of revamping the presentation. Our first step in the project was to make a table of contents that reflected what we had discussed in our meetings. So gathering the conversations we had, the feedback we were given, the ideas that were thrown around the table, we created this first draft of the table of contents. It was originally divided into 3 main categories. So fear of falling as the first thing being addressed in the workbook. Then are you at risk of falls, which encompassed all the non-modifiable risk indicators. And then what can you do to prevent falls, which encompassed all the modifiable internal and external risk factors. In this version of the table of contents, we included some information about kind of what learning strategies we were looking to implement. So you can see we talk about reflexive questions. We talk a bit about checklists on it, what we're going to use, different activities, but not in much detail. There's also an emphasis on the content, so being more specific in what is gonna be included in each section. So once we had this created, we created a Google form and sent it out to everyone who was involved in the meeting at Catherine Booth to get feedback on it. The feedback that came back to us included some information about whether they agreed with what should be included or not, things that we should be including that were not there, as well as some more specific recommendations of how to include this information for the specific target population in a way that's more digestible and pertinent to them. So that was the first draft. After we got that feedback, we created a second draft of the table of contents by encompassing everything that was given to us. So the format ended up looking pretty similar. We still have those fear of falling, what are my risk indicators, and what can I do to prevent falls? Same as the 3 categories before, but with changed language to be a bit more suitable for the workbook and for the population. As well, this table of contents is a lot more streamlined, so we have more specifics of exactly which learning strategies we're implementing and which interactive activities we're implementing. So you can see, we mentioned where the questionnaire is going to be, where the checklists are going to be, where the vignettes, matching games, etc. But it's still split into those same categories that we had all agreed upon at our meeting. We also added a section called My Action Plan to make it more interactive and personalized to each patient. So that section included things like my goals for discharge, my key takeaways, and my questions for my therapist to give a bit more agency to the clients as they're completing their workbooks. So once we had this done, we sent it back out and it got approved by everybody on the team. It also got approved by our faculty supervisor. So we were ready to move forward to the next step of our project, which was the wireframing process. So to do this, essentially what we did is we took the table of contents that we had created and we went through each page of the table of contents and said, okay, which pages can look similar, which are going to be kind of the same, because we wanted to have some sort of continuity in the book and not have a different format on every page. So we were able to pick together which pages should have a similar format. So I'll pass around as well. So this is like the first draft of what we did on a whiteboard, just like in front of everybody, and then we copied each page down. So this is our wireframing process, and essentially what each page is going to look like layout wise. I'll pass it around if anyone wants to look. For those who are online and can't see it, essentially it's just these pages, but with the specific page information on it. So each page is split. So first one being what our section titles are going to look like. Second, what our topic titles, what our activity pages will look like, what checklist pages will look like, what personal information pages will look like, the search and find activities, the exercise pages, the vignette pages, as well as the equipment recommendation pages. So those were kind of the 9 main categories of page design that we had. Again, all with the goal of having more streamlined design so that when people are going through this workbook, they're not guessing what they're going to be doing on each page. They will have a better idea of, based on the format and just by looking at the design, of what's expected from them on each page. So that was important for the learning strategies that we'll mention. So once we had that wireframing process done and we met with our faculty supervisor to go over it and approve the process, we were ready to start with the content creation. So taking all the literature that we had gathered through our searches and applying it to each page of the workbook. So those of you who were more heavily involved in the project, we had emailed it to you, so everyone has it. But if someone who doesn't have the final deliverable our project wants it, Nathalie, Alessia, and I'm Professor Mayo all have it, so they can email it off to you if you'd like. But essentially what we did is we divided between ourselves based on the literature reviews that we had done, the pages of each page of the workbook, and we filled out a detailed content document of what exactly should be included content-wise on each page. Additionally, we created a separate document called Learning Strategies for Older Adults, which encompasses all of the evidence-based learning strategies that we gathered throughout our research that should be used during the design phase of the workbook to make sure that the pages are set up and designed in a way that is best suited for older adults. And again, those are things that can be provided to you if you want, or those of you who are involved in the project have them already in your emails. And then we'll go through.
Okay, so moving on, we'll now present the key findings from our research. We found that fear of fall is a strong predictor of future falls with a consistent and significant association independent of past fall history. Fear of fall also negatively impacts well-being, as it's been shown to reduce quality of life, even in older adults who have never actually fallen. And fear of falls is also linked to an increased fall risk with higher concern scores on falls efficacy scale associated with 12 times more likely to fall compared to those without concern. Fear of fall strongly impacts quality of life across physical and psychological dimensions. There are 2 pathways through which fear of fall affects quality of life. The more common recognized pathways through activity restriction, which then leads to physical deconditioning, reduced strength, and then higher fall risk, which eventually leads to decreased quality of life. The less commonly recognized pathways through decreased self-efficacy, which is less confidence, resulting in poor balance and gait, which then increases the fall risk even without restricting activity. For effective interventions targeting fear of fall, physical activity with more balance, resistance, aerobic, strength training, and Tai Chi has been shown to reduce both fear of fall and fall risk. Combining physical activity with cognitive interventions like CBT and cognitive training can reduce fear of fall in the short term, but it doesn't offer any additional benefits beyond the physical activity alone. And the researchers suggest that this may be due to longer combined sessions, reducing attendance and adherence of older adults. And also, since fear of fall often stems from tangible physical issues such as frailty, poor balance, or deconditioning, which physical activity alone can effectively address.
So now on to the non-modifiable risk indicators. It was found that for previous falls, 2/3 of older adults with a prior fall history are at risk of experiencing another fall. And it was found that it's strongly associated with the vicious cycle of the fear of falling and activity restriction that Nomin previously explained. For peripheral neuropathy, it impairs proprioceptive feedback and cutaneous sensation, which impacts balance due to feelings of unsteadiness. And it also impairs grip strength and hand function and dexterity when it's peripheral neuropathy of the upper extremities. Now onto incontinence. It has been shown that it's linked to the need to rush to the bathroom multiple times and the need to multitask to get to the bathroom, which takes the attention away from the tasks of walking. So for the medical history and conditions, multiple comorbidities were found, such as arthritis, diabetes, and low bone mass density. So it has been shown that these conditions reduce muscle strength and range of motion, gait and proprioceptive changes, and it impairs balance, and it induces dizziness and lightheadedness in some instances. And for vision impairments, it makes it more difficult for the patient to predict the environment and to avoid potential hazards. Glare, if ever they have glare in their eyes, it divides their attention and diverts their focus. And since balance control relies more on vision in older adults, there is a deterioration in balance control if ever they have visual impairments.
When it came to those internal modifiable risk factors, a lot of the research over and over again showed that a multifactorial approach to intervention was most beneficial at reducing fall risk. With a lot of articles citing statistically significant reduction in falls with those multifactorial interventions, which generally included a mix of balance training, strength and resistance training, and some sort of flexibility or functional mobility training. Throughout the article searches, there were kind of 5 main physical skills or physical factors that kind of came up as things to work on to reduce fall risk. So one of those was balance, with a meta-regression suggesting that engaging in 3+ hours of balance training a week had a significant impact on fall prevention in community dwelling older adults. That's just one study by Sherrington et al. Another one that came up often was leg strength. So a meta-analysis showed that a 14% reduction in falls for those who engaged in leg strengthening exercises. So that speaks to the strength training aspect of the multifactorial intervention. As well, core strength was a big one that came up. So targeting core strength through exercise was shown to have improvement in ability to navigate obstacles, which reduced the risk of falls and as well as the fear of falling by improving their confidence and ability to navigate through tighter spaces or messier spaces. The fourth one that came up often was pivoting or stepping exercises, where an article by Montero Dasso et al. Provided level 1A evidence supporting the use of stepping exercises 3 times a week for 12 weeks to reduce fall risk. A last one that we thought was important to include was upper extremity strength and range of motion, because exercises targeting this area of the body were shown to improve response to falls, therefore decreasing the risk of injury post-fall. So it's an important thing to work when you're talking about fall risk reduction. We're not necessarily stopping a fall from happening, but reducing the risk of what comes with it. So working on upper extremity ability is important in this context as well. So these were the 5 things that we wanted to make sure we were including in the workbook when it came to exercises or strengthening, stuff like that. In terms of the internal cognitive factors, there were few that we thought were important to address. So cognitive decline being one, just generally age-related changes in attention, memory, and executive functioning can increase fall risk. If there's decreased attention, awareness of the space around you can be a risk for falls. Lack of memory, knowing to use your walking aid correctly, navigating your space, the layout of things in your house where you left things can be a risk to falling. As well as executive functioning, so planning, making decisions in the moment if there's changes to your environment, if there's a sidewalk that looks different one day than did the next, it can impact your risk of fall. So it's important to consider these age-related changes in cognitive function when we're talking about fall risk reduction. And articles cited interventions for this being something along the lines of balance, strength training, plus home modifications, which is something that we're including in our report. Another important thing was risky behaviors. Cognitive decline can impair judgment and increase engagement in unsafe activities and taking risks and behaviors that lead towards falls. Yeah, this can be problematic in the sense, like kind of what we said before with the executive functioning. Like if you have impaired judgment, you're not making the proper decisions with your body and navigating your environment. So we have to make sure we're addressing that, and studies did it by having personalized risk assessments, providing behavior modification strategies, as well as combined approaches that included that education, exercise, and home safety modification. Another important thing on the effective side that we wanted to address as well was the idea of sorrow. So sorrow is an ongoing emotional response or repeated or continuous loss of health, abilities, identity, and future hopes. It is something separate from depression. But we think it's important to address because it is a big impact on life when people are having injuries or falling in the hospital. It impacts the way they perceive themselves, the way they perceive the world around them. So it needs to be addressed during fall prevention education. Some CBT techniques like general just understanding the illness as well as cognitive reframing strategies can be used to improve spiritual well-being and emotional intelligence in grieving adults, which could help to reduce fall risk in them as well.
And now for the external factors. So the AL conducted a study in 2012 regarding the risk reduction of falling in those who underwent home modifications. So 3 findings were documented. So the first is understanding your environmental hazards. An OT in this study would assess the client's home, pointing out where the hazardous items are, and understanding what is an environmental hazard and removing them can benefit individuals in reducing the risk of falls. Second would be actually making the home modifications. So it's important to note that although it's great that we recommend home modifications and equipment options for clients, having them installed and properly taught on how to use them is what makes the difference in reducing the risk of falls. And then the third was while making home modifications can be effective, allowing adequate room to safely maneuver around one's home is as important as well. And it's crucial that someone can move around their home easily, whether they are walking with or without a walking aid. So moving on to the learning strategies and education for older adults that we found in our results. So the inclusion for fear of falling assessments. Results concluded that it would be beneficial to include a fear of falling in the fall risk assessments, and then following this education with targeted interventions effectively reduces the risk of falls and preserves quality of life. Awareness on preventability. We discovered that if individuals understand personal fall risks and the preventability of falling, they are more likely to take action, which can in turn reduce fall incidences. Education on risk factors and providing clear information on education on fall risk factors can significantly reduce fear of falling and improve quality of life in highly fearful older adults. And additionally, incorporating practical demonstrations or home safety assessments to be interactive and tailored to the target audience was found to be effective. Continuing on, some more learning strategies we concluded through our research is that it should be visually appealing and easy to read with clear typography and composition. Utilizing checklists with clinical guidelines for effective fall prevention education is another method for providing the necessary information. And 2 more educational tools that should be included are raising awareness of modifiable factors and how by understanding that these factors can be modified can lead to better participation in fall prevention behavior. And including education on environmental fall risks using everyday situations in familiar environments through vignettes or video clips can be another alternative method to provide information.
Okay, so moving on, including fall prevention education sessions to increase fall risk knowledge and reduce falls among community dwelling older adults. So it's important to implement fall prevention education, adding motivation strategies to enhance engagement and behavior, enhances engagement and behavior change. So it's important to add motivational strategies. It's also important to personalize the learning by providing practical instructions that are aligned with the daily lives of the use and activities of the users, and also including an outline of learning material for a clear framework, or the outline justifies the relevance of the material, so it helps for the older adults to enhance their learning or education. And also making it interactive, it helps older adults as it improves the focus and memory. And the bigger font size also is improves both usability and legibility, as it reduces the eye movement and fatigue in older adults. And presenting the content in small segments is also helps the learners to learn at their own pace.
So for this, like essentially, we have all that research, we have the results, now it's a matter of implementing it into the workbook that we have. Like we said at the beginning, Emily was explaining, we had to change in direction from a presentation to a workbook. Essentially, like we had said, we had discussed that the idea of a workbook would be more beneficial for the terms of this project, to create a more widely usable knowledge translation tool that can be used both at Catherine Booth, but outside of it as well eventually. So we decided that the workbook would be the best fit because of the learning strategies we had presented, and the need for an interactive tool to help present this information. To us, a workbook is more tangible information that can be reviewed as needed by the client, rather than sitting in one presentation, being there either to take notes or to remember or to look back at the pamphlet later. So it's important to have this workbook that they can refer back to, because it allows for more independent and more personalized learning, because they can go through it at their own pace, they can refer back to it as needed. As well as for the more personalizing aspect of it, their OT or whoever rehab therapist they're working with at the time can go through the workbook with them, provide their feedback on the recommendations in the book, specify it to the conditions and the needs of their patient that they know best at the end of the day, and make it a bit more personalized in that sense, as well as the patient has the opportunity to reflect on their own experiences by answering the personal questions and the reflective activities that are within this book. So it makes it a bit more they have a bit more agency in like this, which was something we discussed with Catherine Booth in this project. Was one of the goals of kind of revamping this fall prevention education was to provide more agency to the patients in reducing their risk of falls. So by having this workbook, we're really putting their rehab in their hands rather than passively hearing in a presentation, but actively engaging in something that can help to reduce their risk of falling. So that's why we switched to it. Then the matter of actually making the workbook. So through all the results that we presented to you, you see the research that we had that was simple enough to transmit into the pages of the workbook. But it really was about making sure that the workbook is following the evidence-based adult learning strategies for older adults. So our goal really was to have something interactive, visually appealing, with large fonts for easy reading, that include images with clear typography and composition, that included motivational strategies to enhance engagement and improve behavior, that included games-based response activities to support the recall of written content, and as well as providing it in a way that's easy to understand and clear with clear written instructions. So more specifically, there were certain things that we spoke about with the learning strategies that we wanted to make sure were included in our workbook. So the idea of having goal setting to improve self-efficacy during educational sessions was implemented into the workbook by having those reflexive questions that are within the book, as well as the last few pages at the end that invites the user to reflect on their own personal goals, write goals with themselves or with their therapist, writing their key takeaways to make sure that they're really taking agency in going through and learning the material. Another important one for us was including vignettes of familiar settings. So it was also to address home habits, but also any other physical, cognitive factors, life circumstances, which are included in the book to help people feel a bit more connected to the material that they're seeing. Fall prevention checklists were a big one that were shown to be effective. Again, engaging in that activity, being aware of what applies to you, what doesn't, having more agency and understanding of your personal conditions can help to reduce fall risk. And then the major thing was the emphasis on education on modifiable risk factors, which is the focus of the workbook. We do have stuff about fear of falling. We have stuff about the non-modifiable risk indicators, but the brunt of it is about those modifiable risk factors. because it's shown that education on this topic can help to reduce the risk of falling and improve quality of life. Because when older adults find out that many falls can be preventable, they're more likely to take action to reduce their risk and potentially lower their risk of falling. Again, playing into that sense of giving agency to the clients at Catherine Booth and anyone who ends up using this workbook to take the steps that they need to take in order to help reduce their risk.
Okay. So here's an example page from the draft book that we produced. The activity is called Reframing Our Thoughts. And the purpose of these pages is to help older adults learn and use cognitive positive reframing to manage difficult emotions, such as sorrow from loss of health or loss of identity related to falls, by promoting positive and realistic thinking. We can combine cognitive reframing, which is an effective management of sorrow, with an interactive and reflective learning strategies to engage learners emotionally and support resilience so that they can better cope with challenging feelings or thoughts in their daily lives.
So while working on our research project throughout the summer, it's important to note that limitations, we face some limitations along the way. So all research projects for our master's degree receive a budget to utilize if needed. Unfortunately, due to the amount that each group is given, and having a few time constraints because we only get 3 months in the summer, we hit a barrier restricting us from further developing our workbook. As OT students and graphic design skills are limited and out of our scope of practice. And we also didn't have the budget to hire a graphic art designer. And this is why we did not include any graphics or images in the draft, except for the images, examples of the search and find activity generated by AI and images found on Google for the exercises and for the equipment. And the pictures for the directional turn exercise is missing, as we could not find an image that properly demonstrates the exercise. And due to limited time for the project, the draft of the workbook has not yet been implemented, monitored, and evaluated with the knowledge users.
So having discussed the limitations of our research project, now we will talk about the recommendations and potential future directions based on our research. So as Carlee mentioned in the limitations, our workbook is just a draft and lacks the appropriate graphics. So because of this, our recommendation would be to have the workbook be completed with the appropriate graphics and images by graphic designer to make it more visually appealing and interactive for older learners, according to the list of learning strategies provided. So one example would be to complete the search and find activity with the relevant images following the answer key that we provided. So once the workbook is completed, the implementation and validation of the workbook in practice would have to be done with an older population in an inpatient rehab setting. So this step would be crucial to continue the process of the action cycle of the knowledge to action model, more specifically steps 5 and 6, which is to monitor and evaluate the outcomes of the KT tool. These steps would have to be completed. So as a suggestion, these steps could be done at Catherine Booth as another student master's project locally. So after the workbook has been implemented and provided effective and reliable outcomes, the workbook could be translated in other languages. So in Quebec, it would be especially beneficial to have the workbook translated in French, since it's a requirement to have publications be available in French under the Charter of the French language. This would also align with step 7 of the knowledge to action model, which is to ensure sustainability of the tool. So this would allow the workbook to reach new knowledge users for long-term integration and accessibility. So as for the implementation of the workbook, it could be used as a whole or in parts at Catherine Booth with its inpatient geriatric population. It could be used as a standalone instead of Catherine Booth's current presentation, or it could be used in complementary with the presentation as a teaching aid to facilitate ongoing practice during and outside instructional time. So in the future, the workbook could be used by other additional inpatient rehabilitation facilities. Thank you.
Well, thank you, everyone. So we'll be taking some questions from the floor and from people online as well. If you can raise your hand, I will say your name so you can ask a question. Thank you.
Thank you.
So, any questions? Stop the sharing.